Hi, my name is Chee-Wee, and in this video, we'll be exploring the use of SIN model as a tool for planning our physical examination. Before we start, I'd like to thank a dear colleague of mine, Kirsty McNulty, for sharing her materials with me, which I've used to develop this series of video lectures. The aims of this set of 3 videos are to help us interpret and extract data from our history-taking and subjective examinations to determine the severity, irritability, and nature of the presenting condition. And through our knowledge of the severity, irritability, and nature of a person's clinical problem, we can proceed to plan our physical examination. In this video, we will be focusing on integrating our analysis of severity, irritability, and nature for planning our physical examination in order to prove or refute our preliminary diagnosis. After we've completed our history taking and thought through our SIN factors, the next step will be to plan for what we'll be doing for our physical examination. One of the key considerations of physical examination planning is to ensure that we accurately obtain the required physical evidence to test our preliminary diagnosis. At the same time, knowing that the patient is suffering and therefore we should avoid aggravating the patient's condition because of our handling of the patient during the examination. How can we know how much to push and how much the patient can tolerate? One simple way is to observe the patient and also to constantly check with the patient if they are okay. Another reason why we would not want to overdo our assessment is because our physical information will be contaminated if the patient's condition is aggravated during testing. Everything will be reported back as painful, and we can't really obtain a clean differentiation between what symptoms we reproduce are due to the condition itself or if it's just us aggravating the symptoms. Another thing to consider when planning our physical examination is to consider what should we be looking out for and be cautious about. Are there any red flags or yellow flags we've identified in our history taking and determination of the SIN factors? This will also inform us on what tests to include to rule out or rule in, that is, test our hypothesis of any serious pathology we may be concerned about. Without going into the details of movement diagrams, there are 4 concepts we need to understand briefly here about it in order to further our discussion on physical examination planning. In movement diagrams, 2 pieces of information are recorded. The first is the patient's reported pain, and the second is the physio's feel of the amount of tissue or joint resistance when moving the joint through its range. For the patient's reported pain, we have P1 and P2. P1 is the very first onset of the patient's pain reported to you whilst you perform the joint or tissue movement. P2 is the point when the pain has reached an unbearable level and the movement is stopped because the patient can't tolerate the pain level any more than is already present. For the clinician's feel or tissue resistance, we have R1 and R2. R1 is the point where you, as the therapist, first start to feel tissue resistance to the movement. It's the initial sensation of stiffness, tightness, or restriction in the tissues being assessed. R2 represents the point of significant tissue resistance, often felt as the firm or hard end field. It's the limit of the available range of motion as determined by tissue stiffness and restriction. With this very brief explanation of what movement diagram concepts are, let's go on now to the use of severity information for our physical examination planning. In our SIN factors, we have determined the severity and irritability for the traffic warden in our case study. We have noted that the patient's condition is of moderate to high severity and also is irritable. Now let's focus on the severity of the condition. The severity of the condition is a crucial consideration on how we'll plan to modify our examination in order to avoid aggravating the patient's symptoms unnecessarily. If a patient's condition is considered mildly severe, we can move the joint to the limit of pain, that is P2. We can also add overpressure at the joint end range to get a sense of what the end field is like. If the patient's condition is moderately severe, we can still move the joint to the limit of pain, that is P2. However, we would not perform overpressure as this will likely aggravate the patient's symptoms much quicker. If the patient's condition is highly severe, we will modify our examination such that we'll only move the patient's joint up to the point where he or she reports the onset of pain, that is P1. We'll also avoid performing overpressures to prevent making the symptoms worse. As you can see, this is in some ways trying to do only as much as is needed to test our hypothesis of what we think the nature of the condition or what our preliminary diagnoses are. Let's now turn to our traffic warden and use what we've learned so far on modifying our examination. We've noted that the patient's symptom is moderate to severe. Let's presume that the patient is on the more severe side of things on the day that he visits you. So when you examine the hip joint, will you be moving the joint to P1, that is just at the onset of pain? Or will you be moving the joint to P2, to the limit of pain? As the patient's condition is highly severe on the day that he visited you, you'll only be moving the hip joint to P1. How about overpressure? Will you be performing an overpressure on a joint? No, you won't be, because the condition is highly severe that day. So the same approach will also be taken when we modify our examination based on the irritability of the patient's condition. For the patient, we have determined that the condition is irritable. Therefore, we'll need to modify our treatment to prevent unnecessarily aggravating the patient's condition. For our case study, we'll need to contract or shrink our physical examination by limiting the number of tests we perform to rule in or rule out our preliminary diagnosis. This is again an efficient approach to physical examination and can sometimes test the clinician's skills in planning and testing. Take for example, if a patient's condition is not irritable or on the low side of things, we can continue to perform the standard array of physical examination. However, this doesn't provide us with carte blanche to perform any test that we want to do. What it does is that it buys us some flexibility to do more thorough examination if required. This is again limited by the amount of time that we probably have with the patient. A side note is that if the patient's condition is mildly severe and not irritable on the day of the visit, the clinician may sometimes face difficulties in reproducing the symptoms and thus have some difficulty in confirming or refuting the working hypothesis of the patient's condition. If this is the case, a simple way to overcome this is to be guided by the functional activities that the patient has reported to aggravate the condition. Replicate those activities to get a sense of what the issue is, but do be careful of not overdoing it if you still want to be on good terms with the patient. Right, so let's apply what we learned for irritability to our case study patient. Given that the patient's condition is irritable, should we be contracting the examination or perform a standard array of tests? Yes, we would want to only choose a limited number of tests that we can use to prove or refute our preliminary hypotheses. This is to prevent unnecessarily aggravating the patient's condition during examination. In our last video, we've discussed what we think may be the patient's condition and have considered several categories of information from our history taking to come up with a preliminary diagnosis. Given a 24 hours presentation of pain, that is, pain is worse in the morning and after resting, and also the pain is progressively worse during the day and is worst at the end of the day. The patient is also woken up at night by the pain, but goes back to sleep after 10 minutes. Now, this is a typical pattern of osteoarthritis. Considering the area of pain, it is likely to be osteoarthritis of the hip. Based on our understanding of the pathophysiology of osteoarthritis, there may be inflammatory processes associated with the articular matrix and triggering subsequent degradation and degeneration of the articular cartilage. This may explain the pain induced when weight bearing on the hip joint surface. The most likely pain mechanism driving the pain experience is likely to be nociceptive in nature. It can be a combination of inflammatory nociceptive and also mechanical nociceptive, given the weight-bearing function of the hip joint. Now, over time, the nociceptive element can become sensitized, and the nociceptive signals can be amplified. And it is likely that central sensitization may also develop in later stages of osteoarthritis. Central sensitization may explain the progressively severe and more continuous pain experienced by the sufferer. As for the red flags, do we need to check for any possibilities of serious pathology? We've noted in our last video that there isn't any information to suggest that serious pathology is present, so we can relax for now on this front until some evidence suggests that we need to revisit this. For the yellow flags, is there any information that may suggest unhelpful beliefs that may serve as a barrier to the patient's recovery? At this point, we know that the patient is off work, so that may be an issue if this persists for the longer term. However, we've not been presented with enough information to determine if the patient has developed unhelpful beliefs about his condition. So we'll need to ask the appropriate questions again, more appropriate questions to gain more information about the patient's beliefs about the condition and their psychological and social well-being. Now, this information will be important when we plan for the treatment of the patient and to incorporate appropriate behavior change and educational interventions. So taking into consideration of our preliminary diagnosis or nature of the patient's condition, what tests must we do on this visit to test out the working hypothesis of hip osteoarthritis? In addition to the usual observational physical examination, for example, looking at the symmetry of the patient's posture and also getting the patient to perform some basic functional movements, our tests that we'll be using will be largely focused on the hip region, specifically the hip joint. As mentioned in our last video, we know that the most restricted hip movement in hip osteoarthritis are hip internal rotation and hip flexion. So these will be included in our list of tests to perform. And due to the severity, we'll only be performing the range of motion testing to the onset of pain, that is only to P1. Some clinicians may argue that we can also perform a hip quadrant test to rule in the possibility of a hip joint dysfunction. If you're planning to do this, this should be approached carefully and only to the onset of pain. It is unlikely that you'll be able to perform the complete test due to the severity of the patient's condition. The test itself is not specifically diagnosing for osteoarthritis and only demonstrate a generic hip dysfunction if tested positive. The evidence shows that the sensitivity of the test, the hip quadrant test, for osteoarthritis is about 75% and the specificity is about only 43%. This means that if the test is positive, it is likely that there is a hip dysfunction, but if the test is negative, you can't say for sure that it may not be osteoarthritis. So this test has its limitations. We will also want to check if active range of motion is limited by pain. So we'll need to test for active hip movements that is important for functional movements important to the patient. Some important functional activities are walking, stairs climbing, sitting, and most of these activities require hip flexion, extension, and a little abduction and adduction. Sometimes the inactivity and the pain may contribute to disuse weakness of the lower limb muscles. So you may also want to test the power of the relevant lower limb muscles to determine if this has actually happened. What I've mentioned are a quick overview of some of the important tests that we should be performing to prove or refute our preliminary diagnosis. And these tests must be performed on this first visit to get a baseline of the patient's condition. If we are planning to do any other tests that are peripheral to what is needed to determine the preliminary diagnosis, then these should be done on the next visit or could be done in the later visits. These tests are not as important and therefore can be performed if you have the time or if the patient can tolerate it. The key principle is to prevent unnecessary aggravation of the patient's condition, but at the same time being able to obtain sufficient evidence to confirm or refute your preliminary diagnosis. To recap, in this series of videos, we have looked at how we can use the sin factors to help us plan for our physical examination and to prioritize the necessary tests to not aggravate the patient's condition. This is only a simple overview of how we can use sin factors as a planning framework. For more complex patients, this framework will serve as a slightly more systematic way of organizing your physical examination to help with your clinical reasoning process. I hope you have found this video helpful, and do remember that the process of clinical reasoning is developed with practice and best done through learning from your peers and from experts. All right, thanks for listening, and I'll see you around.